divide psychiatrists into the different types. Like there's general adult psychiatry, then there's geriatric psychiatry. You know, there's a child and adolescent psychiatrist, forensics, which is a psychiatrist that evaluates people to see if they're sane, I guess, or they're competent to stand trial for some crime that they've committed. Obviously, a lot of times people, you know, if they have a mental illness, if you have some kind of brain illness, it affects your behavior, affects how you look at the world and everything. And so sometimes you'll commit a crime when you're mentally ill. Okay, when your illness is at its worst. And you know, there are laws to protect people that do those things. And so you have to have a psychiatrist that would come in and evaluate those folks to see were they really truly, you know, psychiatrically ill at the time that they committed the crime. And that's a forensic psychiatrist. So there are all different types. And really, the gist of this is, you know, if anybody's interested in psychiatry, it's a great field to be in because you can, you know, there's not enough, first of all, so that means you can go anywhere you want to work. You can probably go anywhere you want to do residency and training as well. And then once you get out, the field's, it's wide open. You can do any type of psychiatry you want, any age group or anything. So, any questions up to this point about any of this stuff? Not so far. Okay. Another question is, that I get all the time, do psychiatrists really shrink heads? You know, are they really shrinks? I mean, not so much really. I guess, you know, what do you expect when you go to see a psychiatrist? You know, that's really what we're getting at. I mean, people get so fearful of going to see a psychiatrist. I mean, every single person after they get through seeing me, they're like, geez, I don't know what I'm scared of. But it's, again, it's society. It's this big myth or something, a big stigma, you know. But here's what you'd expect. I mean, it's really just like seeing your family doctor, okay? You call up to schedule an appointment. Usually somebody takes your insurance information, says, okay, well, you know, your insurance is accepted here, we'll see you. Then you schedule an appointment. You go and you sit in a waiting room just like any other waiting room. Looks just like a family doctor's office. Usually the doctor's late, just about like any other doctor, okay? And all jokes aside, I mean, that's typically, usually, and not always, but usually that's because the doctor has a limited time with each patient and somebody's needed a little more time, you know, and maybe if you're at the end of the day, a lot of people needed more time. By the time he gets to you, it's, you know, he's running 2 hours behind or something. Well, hopefully not that far, but, you know, half an hour behind or something like that. So, you know, you wait to see him. Then you go in to see the psychiatrist, and during the first session, it's usually 30 minutes at least, and for me it was 60 to 90 minutes, or maybe even longer. I got kind of windy, as you can imagine, listening to the talk up here. But in that first session, the psychiatrist is going to try to get to know everything about the person that they can in that time. And that entails things like, not only things like, I mean, obviously the first question is what brought you here? You know, what's going on that brought you here? So then they'll ask all about the symptoms that the person's having, and they'll ask, you know, how long they've been going on, all these things. Take as good a history as they can, because obviously in psychiatry, like I said, there's no brain scan, there's no blood test. I mean, it's all based on history. So we have to be very good at taking the good history. We get this, we call it a psych review of systems. It's basically reviewing all the different, have you ever been manic? Have you ever been psychotic? Have you ever had depression? Have you ever had anxiety? We ask all about the different kinds of anxiety, all these things. It's a lot of stuff. And we kind of narrow it down to what's really bothering them. And then we go into a medical history, which is just like your family doctor. Allergic to any medicines? Do you have any illnesses? I specifically always ask about head injuries. Seizures, head injuries and seizures I ask about, but surgeries also we ask about, other medications you take. Then we go into psychiatric history. You ever seen a psychiatrist? Have you ever attempted suicide? Have you ever been hospitalized for psychiatric reasons? And so on. A social history. Do you smoke? Do you drink? Have you ever used any drugs? All those things obviously can affect how you think, you know, and how you present the symptoms you have. Even caffeine. I always ask people, I do a pretty good caffeine evaluation because at one point I had a patient come in with extreme anxiety, and I was taking the history, and if I hadn't asked, I wouldn't have known, but she said she drank a case of Mountain Dew a day. And I said, well, you know, before we start any medicine, how about we just wean the caffeine a little bit? And, you know, sure enough, she didn't need any medicine. So, you know, you got to ask these things, okay? So, you know, other things in social history, and I think some of this stuff people get uncomfortable about, and maybe this is where the head shrinking thing comes in, but, you know, we ask about childhood history and development history. So we ask about, have you ever been abused? Any sexual abuse, physical abuse, anything like that? Those things are very uncomfortable for people, but as you can imagine, they certainly affect how you develop and how you grow up and how you look at the world, you know. And so if the psychiatrist doesn't know if that stuff is going on, it's kind of like he's blind, you know. Whether she's got one eye patched or something, she's not seeing the whole picture. If they don't know that stuff. Family history is incredibly important. That one's getting better, but in the old days, folks they didn't have names for these things. Well, mom laid in bed for 2 years, but we didn't know it was depression. We didn't call it depression. We didn't know what it was. We called it sleeping sickness or something. So the family history, you do the best you can. It's just not very reliable a lot of times. It's hard for folks to, you just tend to think, well, that was just mom, or that was just dad. That's just the way grandma was, you know. And so you do the best you can with that, but sometimes you don't get as much as you'd like. We do tend to check, depending on the person, we'll check some memory, we'll check, we'll check different things in the brain, the functions of the brain, abstraction is one, so we'll give somebody a little proverb, let's say like, the rolling stone gathers no moss, and we'll ask them, what does that mean to you? With the ability of testing to see, can they abstract in their thinking, or are they very concrete? And if they're very concrete, they'll just say, well, the stone rolls down the hill and it won't gather moss because it's rolling down the hill. If they're abstract, they may be able to say something like, well, it means that the person that keeps on moving doesn't develop any kind of history or skeletons or any moss, so to speak. They keep on moving. So they're able to abstract. Don't cry over spilled milk is another one. So we'll ask some of those things. But other than that, I mean, at the end of the session, usually the psychiatrist, either they can tell you what they think is going on right away. It's pretty easy and they've diagnosed it right away. Or if they can't, sometimes I would tell folks, look, I got it narrowed down to 2 or 3 things, and the brain can have as many diseases as it pleases, so it could really be 3 things. But at this point, I'm not sure. Here's what I think it is. Here's the 3 things. I want you to look up some stuff about it, or here's a book to read about it, or talk to your family about it, or whatever, a pamphlet. And then the person goes away and thinks about it for a while, and then we eventually next session, maybe we come up with the idea of at least what we're going to focus on. But a lot of times we can tell just about after the first session what's going on, and we get some treatment started for the person. Usually then we have the person come back. If we're doing psychotherapy, which is a little more rare, we'll get into that in a second. It's a little more rare, but if we're doing psychotherapy or if you're seeing a psychotherapist, you know what that means, right? Psychotherapy, basically talk therapy, where you're talking to the person and you're making changes. I'll go into a second. For example, I'll give you some real life case in a second about what kind of thing you might do in psychotherapy. But it's the talking, not the medication part. And that is usually done every week to 2 weeks or so, especially in the beginning. The medication part, sometimes the medicines take a while to work, so the doctors will not maybe see you back for 3 weeks, 4 weeks, something like that. And so we're talking about seeing a psychiatrist, that's sort of in a clinic. But if it was in a hospital, let's say a person's in a psychiatric hospital, or even in a medical hospital, the psychiatrist would do all the same stuff the first time they see them, but they just probably would see them more often, so they might see them every day. Especially in a psychiatric hospital, I would see my patients every day on the weekends when I was there. Really, no hocus pocus. I mean, there's nothing weird about that. At least I don't think there's anything weird. Does it seem like anything weird to you guys about that? I mean, it's just basically talking. As a patient, you just sit and talk to your doctor. You tell them your history. It doesn't seem like anything earth-shattering to me, but I think that, again, it's misunderstanding. People don't know what's going to happen. I think they still think they're going to lay on a bed, and the psychiatrist is going to sit there at the head of the bed, not look at them, and do psychoanalysis. And I'm sure there are people that still do that sometimes these days, but not very often. There are still psychoanalysts, but I don't know too many that have the person lay down and do the old Freudian stuff. So,
what's the cognitive behavioral therapy?
Excellent question.
Well, it's different than what they used to do, right?
Yes. In psychoanalysis, let me go explain for everybody how that was done. I mean, it was much more passive on the psychotherapist part. So the patient would do all the talking, the psychotherapist would just listen, and every once in a while they'd interject something like, well, how did that make you feel? Or something, you hear that.